Okay, we are going to get started. I apologize for the late start. We were just getting everything sorted out. But I am going to begin the webinar for the day. My name is Megan Arias. I'm the Training and Organizational Development Manager at Healthcare Education and Training, or HCET, with my presenters here today, Lauren and Courtney. I'm just going to give a brief overview of what HCET is. So our mission is to provide comprehensive program development, education, and training to improve reproductive and sexual health outcomes. And HCET is an organization of passionate people who are proactive in their belief that access to evidence-based, medically accurate reproductive and sexual health education, training, and care is a fundamental right. This webinar has closed captionings available, and to enable those, you're going to hover over your screen and at the bottom, click Live Transcript, and then you'll click Show Subtitles. And you can change the subtitle settings by clicking Subtitle Settings in that tab. Next slide, please. Thank you. So throughout the presentation, we encourage you to submit your questions via the Q&A box. Again, to submit a question, you're going to hover over that main screen, and at the bottom, there should be an icon that says Q&A. And once you click that open, text box should appear where you can enter in your question. And you can send a question at any time during the presentation. We encourage that, and all questions will be answered at the end of the webinar during that designated time. And you can make your question anonymous through the Q&A box, which is why we ask you send it through the Q&A, just so if you want that option, it is available to you. Next slide. So be sure to follow HCET on all of our various social media platforms just to keep up to date with any new information or any events that we are having at HCET. Next slide. Thank you. So just a quick housekeeping information. A link to complete the event evaluation will be sent to you at the end of this training. It'll be sent in the chat as well as in an email later this afternoon. Your feedback is greatly appreciated at HCET. It helps us drive webinars and in-person events in the future to meet the needs of our audience. And you can find any archived presentations and a list of upcoming events on our website at hcet.org. And just to be a notice is our website is currently being renovated, so it is a bit trickier to find, but there should be a tab at the top that says trainings, and you will be able to find a list of past and upcoming trainings. And if you have any technical difficulties during this presentation, please contact updates at hcet.org, and somebody will be able to help you. So in order to receive nursing contact hours for this presentation, you must do the 3 things listed, which is attend the entire webinar, return the completed participant evaluation and post-test, and complete the nursing contact hour form and email it to kbradford@hcet.org. And that form and this information will be included in that email that you will receive this afternoon once the webinar has concluded. So no need to scramble to write all of this down. It will be sent again. Next slide. Thank you. No one with the ability to control content of this activity has a relevant financial relationship to disclose with an ineligible company. Next slide. Thank you. So now I'm going to introduce our presenters for today. First, we have Lauren Canary. They are the Public Health Advisor and former Director of the National Viral Hepatitis Roundtable. They hold a master's degree in public health from Emory University and served for 5 years as an infectious disease epidemiologist at the U.S. Centers for Disease Control and Prevention. They have served on the board of directors of the Atlanta Harm Reduction Coalition and Virginia Harm Reduction Coalition. They completed a fellowship with the National Rural Health Association and has served on its Rural Health Congress. Lauren is currently pursuing a medical degree at the Virginia Tech Carolyn School of Medicine in Roanoke, Virginia. as a scholar with the National Health Service Corps. And then we have Courtney Downs. They are a viral hepatitis treatment coordinator and health educator with Virginia Harm Reduction Coalition. She's a peer recovery specialist and co-chair of the Virginia Hepatitis Coalition. She came to VHRC with an extensive background of lived experience and professional pursuits that enabled her to provide exceptional, innovative, trauma-informed care to a culturally diverse participant population, recovering from mental illness, homelessness, substance use disorder, domestic violence, and trauma. Courtney previously worked as a permanent supportive housing case manager. She also has prior experience working as an emergency medical technician and registered nurse, specializing in neurotrauma, wound care, and public health nursing. She continues to advocate for her community throughout compassion and tolerance. So without further ado, I'm going to pass it over to our presenters.
Thank you all so much for being here today. We have so much to cover. And I'm looking forward to kind of sharing this with you as we talk about what we should be doing to address viral hepatitis among people that use drugs. And I know this is work that you all are quite familiar with. I understand a lot of our participants here are in the Midwest, in Indiana and Wisconsin, and you all have been doing this work for a long time. We're hoping to share some kind of bird's eye view of what's going on, but also some boots on the ground strategies, thanks to Courtney and the great work she's doing here in Southwest Virginia. And we have a lot to cover today, so I'll fly through some of these slides a little quickly so we can get into the nitty gritty. The real meat of the presentation, I think, is the gems that Courtney's going to share with you. We want to give you a sense of trends that we're seeing nationally and strategies for addressing this epidemic among people that use drugs. So as an epidemiologist, I'd be remiss if I didn't go through some of the facts and figures. And while a lot of our talk will focus on hepatitis C, I really did want to highlight some of our other viral hepatitis trends that we're seeing in this population, because of course, none of these occur in a vacuum. Hepatitis A has really been on the scene in this population since about 2016, 2017. I was at the CDC at the time, and we saw the sort of unprecedented rise in hepatitis A outbreaks among people that use drugs and people that are unstably housed. The nature of the virus, of course, is that those who may have a lack of sanitation access are much more likely to contract the condition. And unfortunately, even though it's vaccine preventable, a lot of folks aren't covered by that vaccine at this time. Over the course of this time period since 2017, we've seen over 44,000 infections among folks that use drugs or are unstably housed. And unfortunately, nearly 2/3 are hospitalized, I think owing to the fact that a lot of individuals in this setting have underlying liver disease. And unfortunately, we have hundreds of unnecessary deaths from this vaccine preventable condition. Our surveillance data suggests that we're seeing a downturn potentially in the outbreaks among this population. Of course, I really encourage local health departments to be mindful of vaccinating folks before such an outbreak comes to their community. We certainly saw this in recent years in Southwest Virginia, unfortunately. In our work, it's been helpful to partner with organizations that support people that use drugs, including our comprehensive harm reduction programs to offer vaccination. Even one dose offers some protection. And of course, we've had, we'll talk a little more about this, but we've had good success with using incentives to ensure that the target populations listed here are indeed receiving this vaccine amid the many other challenges of their lived experience. Hepatitis B is another one we're greatly concerned about at the national level. It's a leading cause of cirrhosis and liver cancer in the US. Our surveillance is really limited. Again, probably not a surprise to all of y'all that are working in the public health space. Viral hepatitis is underfunded. Hepatitis B specifically is even more so. Unfortunately, given that limited surveillance, our estimates that about potentially 1.7 million people are harboring hepatitis B is certainly an underestimate. We do know that about 2 out of every 3 people living with hepatitis B in the country have no idea they have it. And about 1 in 5 people that inject drugs are likely living with this condition. There's a lot more that we could be doing in harm reduction spaces and those nonprofits that serve people that use drugs to ensure that we're detecting this and vaccinating folks who may not already be harboring it. I'll let you know that as you consider, again, surveillance data and all its limitations with regards to funding, we should also keep in mind the limitations that COVID presented with detecting new cases. We've seen in national figures a downturn in cases across all age groups since 2020. We know that that's likely an artifact just from lack of detection and access to healthcare during COVID. I just wanted to draw your attention to these two age groups, folks in their 40s and 50s in particular, that did not have the benefit of accessing hepatitis B vaccination when it became available in the early 90s. Those really are our target groups for identifying those folks and getting them protected. Courtney can really, again, speak more to how to reach the population that most needs this vaccine. But we found that, investing in getting folks vaccinated, using incentives to get folks vaccinated is great. There's a 2-dose vaccine available rather than a 6-dose vaccine. Makes it a little bit easier to get folks fully covered. And hepatitis C treatment is a great way for us to encourage folks to get their serology detected and understand whether folks are living with hepatitis B, whether they've been protected by vaccination or not, to move forward appropriately with next steps. Hepatitis C, again, will be the focus of a lot of our discussion today and the work that Courtney is doing. But just wanted to note that, of course, despite the availability of really effective direct-acting antivirals, particularly as they came on the scene around 2014, we've still been seeing an uptick in acute infections. We have new prevalence estimates were released just this past month at the liver meeting that show that we think we have about 4 million people nationally living with hepatitis C. This is the same figure that we had about 10 years ago, which is concerning because it seems as though while we are treating individuals, getting a lot of folks cured of this condition, we have just as many that are coming on board with new infections. So we've got to really consider what we're doing to limit these new infections and get at the hep C at the source, which is substance use, unsafe substance use. All this is to say, from my perspective, working in this field for a decade from public health and policy standpoints, now clinical, I think we're really failing to adequately address viral hepatitis among people that use drugs. We need new ideas. We need to be considering how we're approaching folks. I think it's fair to say that we sort of went after the low-hanging fruit when those hep C antivirals became readily available. I think we did a great job of getting it out to middle and upper income baby boomers. And I think that will affect our prevalence of liver cancer, which is wonderful. But I do worry that if we try to use those same strategies that we did to reach a low-hanging fruit, we're not going to be able to reach the individuals who need different strategies. And that will be a lot of our approach today, and considering how we can engage these individuals, and perhaps more importantly, who we need to have at the table as we're designing those programs to best reach the folks that are not the quote unquote low-hanging fruit. So I think to dive into that, Courtney and I thought it would be good to just better understand the context, really take a step back and understand what is it like for someone to live with substance use? What does that lived experience look like as we're considering our programs? And while this won't be a talk on harm reduction, I just want to let you all know that the framework from which we are approaching individuals and doing the work we do is informed by a harm reduction paradigm. And Wisconsin, Indiana are places that have a long history of really amazing work in the harm reduction space. And so I know this probably doesn't come as any surprise to you, but if you do want to learn more about harm reduction, I'd encourage you to look at the National Harm Reduction Coalition's webpage. Lots of great resources about the principles of non-judgment that we use to approach folks compassionately.
So this is where I'm going to jump in and talk a little bit about substance use. We definitely have moved away towards older definitions of addiction and substance use. We now know that like substance use exists on a continuum that ranges all the way from abstinence to chaotic use and everything between. So
yeah, we like to meet people anywhere they are on the spectrum and not kind of require them to reach abstinence to serve them, but we can really consider our approach and really tailor it differently depending on where someone is on that spectrum. I think that's been helpful in me talking to Courtney is just, what does life look like for these individuals we're trying to serve? What does it look like to live unhoused and using drugs?
So one of the things I appreciate is this full circle moment where I can use my past experience and a lot of the pain and trauma that I went through to serve the greater good. And so here's an example of just a typical day for an unhoused person who uses drugs. A lot of this varies on whether or not, weather is in consideration, whether or not, they're able to be housed in a shelter or unhoused. So, pretty much you wake up and you are consistently in a state of survival. And, all this is not set in stone. It all varies, but yeah, you will see as we're clicking, if your day starts off really early, to even just get up to get out of a public area. Let's say if you're sleeping outside or if you're at a shelter, you usually have to get up, strip your bed. Um, any kind of services, sometimes you have to be in line real early for housing services, even though they don't open at 8, they'll only take the first 10 people, so you got to be there at 6. A lot of times, throughout this whole process, you're going through trying to stave off withdrawal symptoms or DTs. So you're trying to get a few dollars for that. If the weather's bad, you might hang out at the library, or to a day shelter. Sometimes if you were up all night, um, you might go to the day shelter to finally have a safe place to sleep. Um, find places to shower or wash up that's will allow you to do that. You're all balancing this between any community meal times, um, and a lot of walking. You have to put that in there as well. A lot of hustling, just trying to make a dollar. You know, you would, a lot of people say, well, why aren't people looking for jobs? Well, if you couldn't get that shower and you couldn't find anywhere to stash your belongings, you know what I'm saying? You can't spend that time looking for jobs or going to appointments and stuff. It's literally, you're just always in a state of survival. So, and then usually by evening time, you're trying to get your belly full and figure out where the safe place to sleep for the night is, and how you're going to stave off those withdrawals through the night and make it to the next day. And it, it it's a pretty, full-time job being homeless.
Mm-hmm. Absolutely. It's been really eye-opening to learn from Courtney what that really looks like, and just the challenge day to day of physically even all that's involved in trying to survive each day. And it got me to thinking a lot about Maslow's hierarchy of needs. And it sounds like a lot of folks obviously in this population are really at this base of the triangle here, just trying to fulfill their physiological needs: shelter, food, safety, feeling well, staving off withdrawals. Particularly, again, when we think about that spectrum of substance use, folks who are in chaotic use, struggling every day to survive. And it just makes me wonder, how are we asking someone to prioritize hepatitis C treatment amid all of this when they're just trying to get their basic survival needs met? And I think that we can do it, but I think we must take into account this context and really frame everything that we're doing to fit in with the priorities that these folks are experiencing when they don't know where they're going to sleep tonight. Are they really going to be that motivated to take an hour out of their day, not getting a few dollars, hustling, to do a blood draw? It's probably not really realistic, unless we're really considering how to approach folks in a way that really aligns with what they're going through. That being said, again, Courtney's doing really amazing work to engage folks, meet them where they are, using her experience, her PhD in the streets, as we call it, to really meet folks where they are. And I'm really excited for her to share with you her model and how she's been effectively able to reach these individuals. The work that she's done is here at the Virginia Harm Reduction Coalition, which is a comprehensive syringe services program here in Southwest Virginia. When I moved here several years ago, I helped set up this program. I served on the board, and it's been really wonderful to see it blossom and see the hepatitis C treatment program grow under Courtney's leadership. It's an organization that tries to face health inequities, obviously gives folks safer use supplies, but does a whole lot more than that, as you'll hear from Courtney momentarily.
And the main reason why we do it is because, as you see on one of them designs down there, sharps are disposable, the people are not, we are the mothers and the fathers and the daughters and the sons and all that of people. And, we have been isolated and stigmatized and criminalized, and the old way is not working. We've been fighting an imaginary war on drugs, and it has done nothing but produce more, fatalities and death. And so it's time to do something new.
Absolutely. Yeah, and just so for y'all who have not been to Virginia, I just wanted to outline here where this is happening. VHRC is what we're referred to it. The rest of the presentation is located in Southwest Virginia. There's 2 brick and mortar offices in this region. But of course, y'all have probably seen this map before, the vulnerable counties that was created by a colleague of mine after the Scott County outbreak in Indiana. But trying to serve folks in this vulnerable region in Southwest Virginia. Harm reduction access is really limited in West Virginia based on state law there. So we do get folks that come over the border. But in addition to the brick and mortar office, VHRC does mobile outreach with syringe service programming to sites of high substance use and overdose to ensure that we're trying to save lives, and bundling with our, just our staples of harm reduction programming with their syringe services, naloxone provision. We also do routine testing and vaccination events in partnership with the local health department oftentimes, which have been really successful to be able to offer those services in one place. Here's a list of all the services that VHRC provides, and you can see Courtney here on the van.
Yeah. Yeah. We're so much more, like Lauren said, than just a syringe service. And a lot of people, when they think of harm reduction and the coalition, they automatically go to, oh, y'all the people that hand out needles, but we're not. We're the people that provide care and connection,
So much. You all do so much.
So this is kind of how we track our participants. We use a system called RedCap. I'm sure y'all are familiar with it. But when people come to get any kind of services, we fill out a visit information form or in their intake. And it's a very low barrier type of intake, but questions are asked about their hepatitis C status and if they're interested in any, patient navigation stuff like Hep C treatment. And, a lot of times they're self-reporting that, and I'm able to pull, and I'll talk about that more about how that works, where I'll pull reports of people, that are seeking treatment. So this is pretty much my process, my model. And as you can see, a participant will request, treatment, or they're identified in one of our routine testing events or word of mouth or whatever. We'll go over that, and they're handed off to me, warm handoff to the, especially if they're coming during outreach. Sometimes people just call me directly, but I do a hepatitis C intake, which consists of paperwork, education, prevention counseling, and I develop a plan of care. What are they interested in working on? Because it's not just about the treatment, it's about addressing all social determinants of health that can affect their compliance to the treatment. I then take them for lab work. And I'll show you in a little bit, like I have standing orders, or I set up an appointment with the local health department. But my provider has provided me standing orders. So a lot of times, because so many people get lost to follow up, I just bring them straight to the lab. And in that lab, we get a CBC, CMP, Hep A, Hep B, Hep C panel, HIV, syphilis. So depending on their viral load, if they do not have a viral load, then I just provide some prevention counseling, link them to some supplies, kind of talk about what they can do, what they're willing to do, to mitigate the risk. So associate it with drug use. If they do have a positive viral load, I then refer them through another RedCap form to my telehealth provider. So as I guide them through this process, I like to tell them they're doing the work, but I'm doing the heavy lifting. The telehealth team coordinates everything through me. We schedule an appointment. We have the appointment, and it's telehealth. So sometimes it's done in my office, sometimes it's done in my car, sometimes it's done in an encampment or an abandoned house, wherever I need to go to meet the people, and then once they are prescribed the medication, sometimes they might need an additional ultrasound depending on their FIB-4 score. But the medication is then mailed to me, and depending on their housing status and the level of chaotic use in their life, we make a plan for what is best for them for medication adherence. We have lockers where if they're unhoused, they can store their medications in the lockers and come and pick them up weekly, sometimes every 3 days. It's really very person-centered. Um, I check in with them in about a week to make sure they're not, that they're complying with their medicine and but that they're also managing their side effects, which is a little harder when you're unhoused. It's a little harder to manage side effects when, you're also managing withdrawal. And then after that, it says weekly check-ins, but it really is dependent on the person and their needs. At about the midway point, after like depending on the medicine, um, but at the midway point, we provide um new toothbrushes, new razors. We have them switch all that out so they don't reinfect themselves, and then they complete their treatment, and we have to wait 12 weeks, and then we do another lab draw to establish sustained virological response.
Great. Yeah, and I'll note that one of our goals is in order to eliminate the potential loss to follow-up associated with the blood draw, we're hoping to transition that to be on site this year. We're considering any kind of regulations around phlebotomy training that's needed, that we could do that on site. There's a lot of excitement around potential rapid antigen tests that could be in the pipeline. If nationally we commit to hepatitis C elimination, I know there'll be a fast track for that with FDA approval. There's also excitement around dried blood spot testing. And I know we're all hoping that we can get to a place where we have same day treatment initiation for hepatitis C. But until we're there, of course, trying to do as much as we can to eliminate those barriers. And I do hope that once we have blood draws on site, we can get that process going without that extra step of Courtney taking folks to the lab. But she's so committed that she makes it work anyways. And really does great work.
And I work on 3 to 5 participants at a time. So there's so much wraparound care that goes into whether it's getting people's Medicaid or IDs and services like SNAP and food stamps, that it's really almost I've done more than 3 to 5 people, but it really gets a little difficult. So these are some of the, nitty-gritty considerations that I think, I do a little differently than other programs. One is I have a knack for maintaining connections, and so we have many ways that I maintain these connections. We have the drop-in center times for them to just walk in. I make flyers. You can see an example of one of my flyers that I make that I put out into the community, or I put in our supply bags. There's I help them with getting like phones. We have a QR code for social media, Facebook, Instagram. Sometimes we get donated cell phones, or I help them apply for what is colloquially known as the Obama phone, which is, the Affordable Connectivity Act. I'm sure y'all have heard of it. And a lot of this requires like a personal knowledge of street family dynamics and the migration of people, because as police are tearing down encampments and people move, and I think it's human nature to look for connection. So even if they're finding connection in their community, they tend to move in groups, and so all of a sudden a spot will go dead, and it's like, where are people at? And they moved, and because of my lived experience, I have that trust in the community to get into those areas and to understand, okay, this person is part of this street family, so I can talk to this person and find out where people are at. These are just different pictures of encampments, us bringing supplies out to the encampments. The one is an abandoned house where I was delivering somebody's medication. That's our little peer cafe, and that top picture is us in collaboration with the health department doing a STI test and go event. All right. So the next thing is about motivational interviewing. And so pretty much, with motivational interviewing, I really, let my people talk, you know. Um, they've been being talked at for a long time, and so I let them talk and I let them practice self-efficacy and self-advocacy, and I let them design their own plans of care. I can tell them all day long what I think they should do, but that's just not working. It isn't. I can provide all the education in the world, but that doesn't work. What is a person willing to do? And this is a stages of change. As you see, it's not a linear process. You can bounce between all of these stages. Sometimes you can exit this wheel completely, and then jump back in. And so just meeting people where they're at in this, if somebody's in pre-contemplation, my place is not to be acting and making preparations. My place is to talk about how do we get from pre-contemplation to contemplation. What does that look like for the person? All right, these are about standing orders. So this is something I'm very proud of. This was done in collaboration with my telehealth provider. So that just pretty much has everything I need, whether they're in the beginning of treatment, the end of treatment, or need an ultrasound. And so I just pop in the information, check off what I need, and bring them to the lab. Challenging venipuncture. So this is the bane of my existence. So as I'm sure you can imagine, people who use IV drugs are not trained in phlebotomy, so they have really tore up veins. And so we have developed a collaboration between one of the commercial labs in conjunction with the health department that I call 15 to 30 minutes before I'm coming in. And I'm like, it's Courtney from VHRC. I'm bringing someone in for labs, and they get somebody called the clinical administrator that has the ultrasound guided machine ready. So by the time I'm in there, they're there, because the fact is, my people are not waiting. They want their gift card and they want to go get well, and this is a picture of ultrasound guided phlebotomy. This is another one of the standing orders I've worked on, is to draw blood out of a foot, a lower extremity, which is something that is required by order in my area. And these are just additional tips. I pump people full of their beverage of their choice, but I try to stick to Gatorade and liquid IVs. I have liquid IVs all over my office. I suggest that they decrease stimulant use for 12 hours prior to the lab. If they can't do that, then I ask them, well, what about 2 hours? And see if they could take a nap, or try to schedule my time with them after they've gotten some sleep. Food insecurity is another consideration. We need nutrition in order to rebuild. Our liver is a beautiful organ. It is the one organ that can regenerate itself if given the proper building blocks. And so we need protein, and people also need food in order to take their medication for optimal absorption. And when you're unhoused, and you can go, I could tell you to go to a food bank all day long, but reality is they're going to give you a bunch of canned foods that you can't carry around, bags of rice that you don't have anywhere to cook. And so I really try to provide easy grab snacks that are non-perishable and protein rich. And this is just an example of our food pantry. This is all done by donations. And our outreach staff, we don't currently have money in our budget for food, but our community really comes through in that area. Managing side effects. So this chart right here in the white shows like what you would normally tell a person to manage these side effects. The three common side effects are nausea, headache, and fatigue. Except some of these interventions are not feasible for people who use drugs and that are unhoused. So like I'm just going to point out a few of them, like lying down and reducing stress level. That's not happening. So what can I do to help that? Well, I have a comfortable couch in my office where I'll put some dim lighting on and let them rest while maybe I'm catching up on some charting, give them a coloring book to do some mindfulness and coloring. That's just some ideas. With the sleeping, like not everybody goes to sleep at 10 o'clock at night, especially if you're surviving through the night. So we tell them take your medication before bedtime, whatever bedtime that is. And these are all things that are discussed when we develop their plan of care. So this is one of my success stories, probably one of my favorites. I met a man who came to, and I'm not going to read the whole thing because it's lengthy. I'm going to let y'all read that, but I'll hit some highlights. He came to outreach and we were having an STI test and go event. He didn't really want to get tested, but he opted because he wanted the gift card. Um, he needed the gift card, I should say. Um, he ended up testing positive for syphilis. The health department could not locate him. So they got back in contact with me. I ended up finding him. I brought him back to the office. We did some paperwork. We talked. I ended up helping him with some food, toiletries, clothing. I gave him a donated cell phone that had a active SIM card in it. I was able to link him to the health department for syphilis treatment. Well, during that process, we found out he was allergic to almost like every antibiotic that they were trying. And so, in collaboration with the doctor at the health department, we developed a plan to give him some prophylactic steroids and Benadryl for 13 hours, 7 hours, and 1 hour prior to his penicillin injection to mitigate any anaphylaxis. And so what that meant was I had to meet him at 12 o'clock at night, you know, later on that morning, you know, and it was great, because he was able to get his syphilis treated. During that whole process, I was able to link him to our telehealth program. While we were doing this, his son ended up dying of an overdose, and his girlfriend almost died in the ICU from a xylazine wound, which I'm sure a lot of y'all have heard of xylazine, what we call trank dope, which is causing really bad tissue necrosis. And so he's dealing with all this stuff, and I kept him engaged through peer support and incentives and, just connection and care. And we were able to address several of his abscesses, which were also caused from the xylazine before he got to the point where he was in the ICU from them. And he started off picking up, 3 day supplies of his meds. He later was able to go up to 7 days at a time. And now he's currently waiting to go into inpatient treatment with a plan of transferring into transitional living.
Such a great example of just how complicated the patients are too that you're working with. And I think from a clinical perspective, how we deliver care, having someone come into a clinic, get a prescription, okay, we'll see in a few months to check in on you. Like there's just no way that this person would have been identified as having Hep C, let alone getting treated, without all the wraparound support and really meeting him where he was and addressing all these complicated factors in his health and in his life. It's, yeah, really speaks the importance of someone like you, Courtney, really going above and beyond for people.
Thank you. So this is another one of my and I have a lot. I'll probably tell you every single one of my success stories. This is my favorite story because it is a lot of time and effort put into them. But this was a unique case where I had someone come in, saw like the flyer and self-reported that they had a previous, rapid test, antibody test. I linked her to a local lab with the standing orders during this whole, and she also wanted to get family planning, STI testing. So I linked her to the health department. During this process, using motivational interviewing and just talking to people like they're people. To me, that's what motivational interviewing is. Talking to people like I'm invested in their answers. I was able to recognize that she was, I put victim of domestic abuse, but a survivor of domestic abuse. Once again, it's important to move away from certain languages, and I'm still working on that. But so I was able to link her to our domestic violence case management. She didn't feel safe going to another sheltering service because of her sexual identity and substance use stigmatizing her in the past. we have a very small grant to put people in hotels. And so she was able to go to a hotel for 30 days, and she received intensive case management for both the domestic violence and hepatitis C. She was linked to telehealth. She got Maverick. She ended up getting linked to employment services and got a job. And then one day when I went to check in with her, I found out that she decided to move to Florida and start new. And I then had to send her medication refill by certified mail to her forwarding address, which, we're also trying to move towards getting the pharmacy to send all 8 weeks of like the Maverick and all 12 weeks. We're not there yet, but situations like this, that would be important, if there wasn't somebody like me willing to send the medication.
Courtney, I've heard a number of times from folks working in this space that perhaps we don't do enough to elevate the benefit of Hep C treatment and all the engagement that goes along with it in this population with their self-efficacy. And I feel like in this case, it seems like being able to really wrap your arms around her in the setting of Hep C treatment allowed you to identify that she even was a victim of domestic violence, get her linked to those resources. She felt supported enough to get employment services and move out of state, somewhere that's perhaps safer for her. And I do wonder if we don't really capture in a lot of our publications and data around Hep C treatment, the benefit of that self-efficacy of tackling something and feeling like I can do it. I can maybe take ownership over something, and maybe Hep C is the first thing and housing or employment could be the next treatment.
Absolutely. And we address things from dental health to housing. I mean, there has even been some things where I've supported people in their legal situations or situations where they're struggling to get their children back and stuff like that. So, I mean, it's all encompassing.
Amazing. Here she is, 9 people to treatment this year.
That was just in a month, actually.
It's incredible.
Yeah.
It's a really difficult population. I think it really speaks to the success of your model and all that you do for folks. I've been trying to, as I've learned from Courtney, taking into account some of the work I've done previously, trying to reach these individuals from a public health perspective, again, from a clinical perspective. I've spoken with Courtney's boss, executive director of HRC, even like, what is the secret? What is the special sauce of all that's Courtney doing? If you could summarize it. And a few takeaways that I've noticed are that, she has such trust with participants. They absolutely trust her. They know she's been there before. They know that she'll go above and beyond for them. She shows up where they need her to, but she also has guardrails, she's not being taken advantage of. And she's really good at having that balance of being trustworthy and such a safe place for people while also having guardrails around what she's doing to protect herself. She also just has such a good knowledge of where people are. She mentioned sort of the nature of the encampments being destroyed, where people are going. She knows where people stay. She knows the kind of lived experience they're dealing with, what their day in and day out looks like, how to find people when they've got a telehealth appointment. She's got a few hours to make sure she finds them, brings them to the office. She knows where to look. It's just, again, that PhD in the streets. I think you can't replace that knowledge. You can't read it in a book. I've also noticed that she has really strong relationships with all the members in the recovery ecosystem in our community, based on her own journey with substance use. And oftentimes she's able to pick up the phone and have a direct line to people at different organizations, whether it's rehab programs, jail, hospital. She's able to kind of get around all the red tape because she calls up someone that whether she's friends with or made a friend with, in order to get this work done. And it's just so effective. Not dealing with the emails going up the chain, over, down the chain. She bypasses all that based on these personal relationships she's fostered. And in doing so, she really does think outside the box to make sure that she gets people their treatment, especially, again, those who've initiated treatment but end up incarcerated, for example. She knows she's got to get them those meds and finds a way to do it. So she's persistent in that way, but she's also patient. As she went through the stages of change model, identified, thinking about how many people that she may have started to work up for treatment who then kind of fall off. And she's able to be patient with that process and understand how complicated this journey is. And I think most importantly, of course, is that she can, despite all of this, despite the challenges of working in this space and all the triggers that can come with having lived experience and working in this space, she's really good at boundary setting and prioritizing self-care. Just so important for her to be able to do this work that she does. So a few key takeaways. I know we can't really summarize the magic that is Courtney in just a few bullet points, but those are some of the takeaways I've noticed. And to me, her success really elevates the importance of engaging people with lived experience and really centering people with lived experience in the work that we do. Courtney and I talked through some of the ways in which it's really important to support people with lived experience when you're employing them. I don't know that we have a ton of time, so we want to have time for Q&A, but we do have some slides here on tips for, considering when you're employing people with lived experience, how you can better support them.
I think the biggest thing I want to point out with this slide is that, I used to be a nurse, and in my chaotic use, I lost my nursing license. And there are so many of us that then see the other side of recovery. We might not have the certifications and the licensures, but we still have all this knowledge. And so my boss called me like a unicorn. I have the lived experience and the medical experience, and there's a lot of us that could be utilized.
Mm-hmm. Absolutely. Yeah, that knowledge doesn't go away, right? I know there's a lot that, I've spoken with Danny Clausen, executive director, about the importance of engaging, folks in professional development, ensuring they feel supported in the professional space, conferences, trainings. It's great.
This is just about, having trauma-informed management, being a trauma-informed workplace. Like, I wouldn't be able to do what I do if I didn't have that support, because it's very often that I have my trauma reactivated or triggers or whatever. And, I can say my staff's really great. My team is great at supporting each other. And the biggest thing on this one is it's so important to have flexibility. Like, there are days I need to work from home. I call them, I don't feel like putting pants on days because my mental health is not 100%. I just had a very difficult case the day before. And you know, being flexible, also honoring the fact that mental health also counts towards sick time.
Mm-hmm. Mm-hmm. Absolutely.
And navigating dual relationships, it can be very difficult when you were a person that lived in the community, and used drugs in the community that you now work with. So, having that conversation, it's going to happen. Being trauma informed enough that when a person comes to you and says like, I don't know how to do this, or I might have messed up, as long as it's not like really bad, being able to give solutions for that, and without the fear of reprisal.
Mm-hmm.
And these are just some warning signs of boundary violations. One of the things I just want to point out is, like, I'm not responsible for anyone's failure or their progress. I'm just their guide. This is their journey. I don't get to own it. And that's very difficult sometimes,
Mm-hmm.
and to be there and to let them know there's no judgment. You know
Mm-hmm.
what I'm saying? It might take quite a few times to completely comply with your medicine or to go to treatment or whatever the goals are.
Mm-hmm.
But it's not my journey to own.
Yeah. I think in the interest of time, I'll just highlight a few key takeaways again as we think larger scale about hepatitis C elimination. What can we take away from Courtney's success in our little corner of the world here? And I think larger scale, again, we have to center people with lived experience. There's no way that we're going to reach this population if we don't have people with lived experience, not only at the table, but truly guiding and creating these programs. Robin Lord Smith was an advisor of mine at the National Viral Hepatitis Roundtable, who would ask me every time I said, oh, I'm going to this meeting, she said, who's missing? Where's the seat at the table for someone with lived experience to be there? And I think it needs to be more than one seat. Obviously, there's a reason why in public health leadership, there's a lot of folks who look like the folks that we have been successfully able to serve with our Hep C treatment, but we have not been engaging in leadership or in program development, those folks who have the same lived experience of those we're needing to reach. So I do think that we need to be elevating this at every meeting and every opportunity. Again, low threshold services, of course, we have to meet people where they are. They have a lot going on. They're trying to survive. We've got to make sure that our goals then can fit in and be streamlined within the goals of their day and just surviving. Incentives have been so key to the work at VHRC and the success of getting people treated for Hep C and also vaccinated for Hep A, Hep B, COVID, flu. Even a very small gift card, $5 or $10 goes a long way. The Virginia Department of Health has been great about allowing us to use funding for gift cards. It took a little bit of wrestling, but I do think that with COVID, we saw states really adopt this and seeing the need for it so that we do have a pathway there. And a $5 or $10 gift card is just a drop in the bucket when it comes to the cost of Hep C treatment. If we're paying people for their time and taking them from the streets for an hour where they can't be panhandling or hustling for a few dollars, let's pay them for their time.
And I just want to add in with that. There are times that people will come to me and say, what can I do to get a gift card? I need to get a pack of cigarettes, and I'll be like, you can get this vaccine or you can get, primary care visit, so they seek out these opportunities to get the gift card.
Usually beneficial. And I think, again, larger scale, if we were able to take out that baseline of Maslow's hierarchy, if we could really ensure that people are stable, their basic survival needs are met, they have a place to sleep, they have food to eat, I think we would save a lot of money on our public health programs. Because just like for Hep C, for every other condition, we're going out and trying to do outreach, linkage to care, access to treatment. And I think if we collectively came together and really help support that safety net, we'd probably save a lot of money in our public health dollars. So I'd love to see some innovative programming around Hep C treatment where we, house people during the duration of their treatment. See how that goes. Again,
it would be a game changer.
Budget drop in the bucket when it comes to the cost of treatment. So with that, again, I know we went through a lot really quickly in hopes that we could share as much as possible. But I think we have a few minutes left for Q&A if folks have any questions. I think
I see some questions in the box.
Yep,
okay.
I can get those
Sure.
read. The first question is, do your providers require the patient to receive a physical exam before they can be prescribed medication, or do they allow all visits to be done virtually?
So they allow all visits to be done virtually. They do a review of systems, with them, sometimes I'll even add things in that they'll be like and that kind of helps with I'll be like, well, what about, they'll ask, do you have any rashes? And they'll be like, no, I don't have any rashes. I'm like, well, what about that on your arm? You want to show the doctor that?
So. Yeah, the benefit of you, Courtney, having that clinical experience, even if your license is not active, you know what jaundice looks like, and I imagine the telehealth provider feels even better about, the fact that you're sitting there with someone during that visit.
Yes.
Next question is, who pays for treatment?
Usually they have Medicaid, state Medicaid, or some people will have Medicare. Very few times I come across commercial insurance, but in the event that they don't have insurance, there's different grant programs that help get the medication and stuff. So we utilize that. And part of the team I work with, they have a whole wealth of resources, which is the Virginia Hep C network.
Yeah, we're grateful to be here in Virginia where we have Medicaid expansion, and not every state is enjoys that privilege. But I do know for those states that do not have Medicaid expansion, there's often opportunities with the manufacture of different medications. If you're having trouble getting treatment covered for a patient, you can reach out to the manufacturer directly. Oftentimes they'll have programs to provide that free of charge. Free clinics are another way to manage that. I know for our uninsured patients, folks who are undocumented, for example, we have a local free clinic that has the arrangement with the Hep C drug manufacturers to get those treatment free of charge. So I don't know the conditions in which Jessica's there is working, but there usually are avenues, thankfully.
Thank you. Next question. Tracy from South Bend's Inc. Says, thank you for what you are doing, and then asks, will there be a recording available? This info is great, and I have already seen things I would like to implement in how we serve and would love to pass this to my directors. Yes, this presentation will be sent out in the follow-up email later this afternoon. Another question about being recorded. Yep. So you can expect this to be sent out again, this afternoon, you'll have this presentation, which includes contact information for Lauren and Courtney, if you would like to follow up with any other questions that you all may have, following this webinar. We do have a few more minutes, so I will just give it a few more minutes before wrapping up to allow for any questions that people may think of.
And one thing we didn't really talk about here is that, you know, the treatment restrictions around hepatitis C treatment.
Yes.
Changed a lot over time. That's something I've worked on again the last 10 years in very different arenas. But we've been fortunate in Virginia to have been able to develop a hepatitis coalition. Again, something when I moved here, we just kind of, a few of us kind of came together and launched it, a provider, a patient, myself, and we were able to advocate with our state Medicaid to get the prior authorization removed entirely, which has helped a lot with the paperwork and delays. NVHR on their website kind of tracks, if you Google state of Hep C, they track the nature of prior authorization requirements in different states. If you need any support advocating for removal of prior auth or reduction of any of those requirements, we're making a lot of progress nationally to do this work. And NVHR, I know, is always happy to support that advocacy work. And oftentimes we'll have patient advocates who may be able to work with you, provider advocates that can work with you to kind of come together. If you don't have a state coalition yet, definitely encourage trying to foster the initiation of one, because even if it's a small group, being able to send that official letter to Medicaid and appeal to them has been really helpful in just kind of moving the needle, reaching out to our legislators when there's opportunities to try to promote funding for harm reduction, for example. Doesn't take too many folks to be able to just have a voice at the table when it comes to some of these things.
Yeah. And if you have any questions, please reach out. If you know any questions about how you can implement these services, like it's really kind of a unique model that sometimes I don't even know it's quite a model, or it's just compassion. But
Courtney going above and beyond. She's amazing.
Thank you. You're amazing.
Incredible. Well, due to time, we're going to wrap up. Thank you so much, Courtney and Lauren, for such a wonderful presentation. I know I enjoyed it, as I am confident those who attended also enjoyed. Like I've said many times, please look out for an email following this webinar. It'll include information about nursing contact hours and how you can obtain those. The slides will be included, as well as a link to evaluation, where your feedback is greatly appreciated. So with that being said, again, thank you so much to our presenters, and thank you to everyone who attended, and have a great rest of your afternoon.
Thank you for having us.
Thank you, HCET. You'll do such amazing work. Really appreciate you.
Yes. Thank you.
Thank you.
All right. Bye.
Have a great day.